Welcome to Plastic Surgery Talk with Dr. Stephen Mulholland, brought to you by SpaMedica. Hello and welcome, Dr. Stephen Mulholland in Toronto, Canada, Plastic Surgery Talk, and welcome to another installment of our podcast series. If you find these engaging, entertaining, educational, please share, subscribe, and comment. Today's podcast is on septoplasty, or the management of airway surgery, the management of airflow in conjunction with cosmetic rhinoplasty. So what is a septoplasty, or what is airway surgery? Airway surgery is the operative intervention on anatomical or functional obstacles to air passing back and forth through the nose without obstruction. There are a number of anatomical components that can get in the way or block the free flow of air and give the sense of inability to breathe through one of your nostril openings and passages. And one of the principal anatomical structures is called the septum, or the partition. It's that partition in the middle of your nose that divides your nose into a right and a left half. And the partition can be straight, in which case the air will often flow in a laminar pattern, and you'll have nice air exchange. However, if your septum tends to be deviated or deflected on one side or the other, it can cause turbulent flow. One side's flowing well, the other is turbulent, and you perceive you can't breathe through one side or the other. So the septum, or the middle partition, can sometimes block one side or the other, and that will often require correction. And the correction of that septum, or its straightening or removal of the crooked part, is called a septoplasty. So what do you get out of a septoplasty? Why is a septoplasty a procedure, and when is it offered? In general, you can get a septoplasty as a standalone procedure with no cosmetic rhinoplasty or nose job. That kind of airway breathing surgery is generally covered by the managed care and healthcare plans of most provinces and states and private insurers. And in my practice as a busy cosmetic nose job and rhinoplasty surgeon, I don't offer septoplasties alone. I offer a cosmetic reduction rhinoplasty or a nose job. And if you have airway issues, concerns, or blockages, then we offer a septoplasty as part of the rhinoplasty procedure. So a septoplasty then corrects airflow, and if we make a nose smaller, so particularly doing reduction rhinoplasty, making the nose narrower, taking the bridge down, we want to make sure that the 4-lane highway, which is the air passages, doesn't become a 2-lane highway and obstruct airflow. So you can have a straight septum, reduce the nose, and still sometimes end up with relative airway constriction. And so we take a look at other anatomical structures too. So the word septoplasty refers to the septum, but often a nasal surgeon like myself will look at other structures like the turbinates, which can encroach from the sidewall, whereas the septum's in the middle, and we may do partial turbinectomy or subtotal turbinectomy, which is reduction of your turbinates. We may look at other internal structures, such as what's called the internal valve, which as you breathe in can close off. And we may do procedures such as spreader grafts to open the internal valve. So when I say I'm going to be doing a reduction rhinoplasty, which includes septoplasty, it really means airway management surgery, which can be septoplasty or management of straightening the septum, a turbinectomy for sidewall obstruction, and internal valve surgery and external valve surgery to make sure there's no functional collapse. So a good nose surgeon, a good cosmetic rhinoplasty surgeon, is always going to be very cognizant and serving your airway as well and providing airway surgery at the same time. So septoplasty and airway surgery is to ensure after your cosmetic reduction rhinoplasty, you still breathe well. So who is a good septoplasty candidate? Well, someone who's undergoing a cosmetic rhinoplasty procedure that has a deviated septum, that either has compromised breathing going into the surgery or may have compromised breathing if we don't do the septoplasty surgery, is usually the most common candidate in my practice. So a patient undergoing a cosmetic rhinoplasty that needs reduction of the septoplasty to ensure or minimize the risk of compromised breathing after. Often the septoplasty is also done to harvest graft material. So we take the cartilage, the stiff cartilage of the septum, and we make tip grafts and support grafts and structural supports for the cosmetic rhinoplasty to ensure a long-term stable outcome and result. So you can be a candidate for septoplasty for breathing and breathing surgery, and also harvest of graft material that's used to structurally support your cosmetic rhinoplasty patient. Patients who have airway obstruction before their rhinoplasty, who are having a reduction rhinoplasty, are clearly indicated for septoplasty procedure. And usually we're good at getting about 90% of patients breathing the same or better after cosmetic rhinoplasty. About 8% of patients, despite the best septoplasty and airway surgery that a surgeon can do, management of all anatomic structures and functional valves that might lead to constricted airway and compromised breathing, can sometimes, in 8% of cases, still love their nose job and feel that one or the other side is slightly compromised. So there's about an 8% risk, despite septoplasty and other functional airway surgery, that your nose looks great, but your airway is slightly compromised. And that's one of the risks of going into a reduction rhinoplasty that patients need to be accepting of. There are very few contraindications to a limited subtotal septoplasty. The indications are harvest of graft material for your structural rhinoplasty procedure or correction of airway. There are some patients, however, who have very limited septum following collagen vascular diseases, and we may need to leave that septum intact. Patients with bleeding disorders or platelet scarcity may not be a good candidate for septoplasty. Patients who have undergone some transnasal abuse of drugs at a younger age, such as cocaine, often have large septal perforations or septal compromise, and they're not good candidates. And so we sort out anatomic, metabolic, and functional reasons why you may not be a septoplasty candidate. But for primary reduction rhinoplasty or making your nose job to form a nasofacial contour that's smaller, virtually every candidate who is healthy is a good candidate for septoplasty, either for graft material for your nose job or for preventative or therapeutic intervention on airway obstruction. So how is septoplasty performed? There are a couple different techniques. There is endonasal or internal septoplasty, where all the surgery is done through one of the nares, and the lining of the septum is lifted off, and the septum is exposed, and a small piece or the deflected part, the obstructed part of the septum, is removed, and then the flaps over the septum are resutured with dissolvable sutures, and that's a pure septoplasty. In general, with reduction rhinoplasty, the septum is operated on during the rhinoplasty, so the skin is lifted up. It is an external approach. The septum is exposed. Enough of support is left behind to structurally support the nose after the surgery, but a relatively large segment of the septum is often removed during reduction rhinoplasty, both to facilitate breathing after and also to have enough graft material for tip support, structural support of the middle third of the vault, tip grafting, other internal valve structural supports. A lot of ways that we use the septum to support the cosmetic rhinoplasty. So we take the septum during a nose job, both for form and breathing and structure of the rhinoplasty itself. When the nose is closed, the flaps are put back up to the residual septum. Internal dissolving sutures are used, and you never see any scars from the septoplasty. They're all internal. In general, if you're undergoing a reduction rhinoplasty and you're taking the bridge down and the sidewalls in, and you've done a preventative septoplasty for airway flow, you will notice that you've had a successful septoplasty when your reduction rhinoplasty looks great and you're breathing the same or better. That was only achieved by your surgeon doing an excellent job at airway management surgery, looking at all the relative obstructive lesions, turbinates, internal, external valve, and septum, and addressing them while making your nose smaller. So you have a smaller nose that you breathe the same through. That's a great result, and you know your septoplasty was successful. You know you're successful with your septoplasty if you had airway obstruction, that you can't breathe through one side or the other, you had your nose operated on, and you had your septum operate on as well, and you have a nice nose job, and your obstruction becomes clear or improved airflow in the face of a smaller nose. That's, again, airway flow improved, successful indication that your septoplasty went well. What's an indication that it didn't go as well as anticipated? You have airway obstruction after your reduction rhinoplasty. There's one side of the nose or the other that doesn't breathe as well. That may be due to a variety of factors, septum being one of them. And you'd revisit with your nasal surgeon after about 6 months, because it takes about 6 months for the internal environment to settle, to truly manifest the kind of airflow you're going to have after a cosmetic rhinoplasty. What's to recover from a septoplasty? The recovery period can be measured in short-term recovery and then long-term recovery. Short-term recovery is the healing of the risk of the septum oozing or bleeding after. So invariably, after a septoplasty where the linings are quite fragile and we restitch the linings, some type of packing control is performed by your surgeon. Some surgeons use little hollow tubes that they put down each nostril and suture those to the septum so you can breathe through your nose while compression is placed against the lining of the septum for 5 to 7 days. Then those are removed, and then the risk of having a post-septoplasty nosebleed is very low. It can still occur, but it's very low. Other surgeons still will use more of a traditional technique where the nose is packed on either side with a soft, Vaseline impregnated packing gauze, and that gauze is removed on day 3 to 5, and by removing the gauze you can then breathe again. But you haven't been able to breathe during that 3 to 5 day period, and you've been an obligate mouth breather. That would be the typical packing, the traditional packing technique, versus the insertion of the compression open airway nasal tubes. Either way, your surgeon can select with you one of those two techniques to minimize bleeding. So the short-term recovery is the removal of the packing technique. Once the packing technique is removed, you still may have a little airway obstruction because there's a lot of swelling and edema inside the nasal mucosa, or the lining of the nose. And so don't be alarmed if you're still a little obstructed, because it takes about 6 months or more for long-term recovery or long-term healing, which is the resolution of optimal airflow after septoplasty, turbinate, and maybe internal valve surgery. By about 3 months, 3 to 6 months, the airflow you're experiencing then will probably be the terminal airflow you can expect after your internal airway surgery, and that's the long-term recovery. Short-term, minimizing the risk of bleeding. Long-term, optimizing the recovery of airflow after your septoplasty surgery. So what are the side effects or the complications of septoplasty surgery? The number one side effect is you may do a septoplasty or internal airway surgery with turbinates and valves, and you may still have obstruction, so residual or persistent obstruction. You may have a completely normal airway with patent airflow, do reduction rhinoplasty and functional airway surgery, and have one side or the other that's compromised. So new onset airway obstruction can occur after airway surgery, including septoplasty. There may be increased risk of minor nosebleeds during the winter months because you have dry air and you have scar tissue on the septal lining, and it's not as, doesn't make as much mucus, and you may have the odd little nosebleed once or twice during the winter months. So have a humidifier in the room, minimize in and out inhalation of dry air. There may also be some areas of pain or discomfort while you're healing. And with septal surgery, you may actually have some change in smell and the persistence of certain smells, especially if there's an area of dryness or crusting. You may have ongoing crusting and nasal cleaning that you need to perform after septoplasty. That can also occur. So those are the short and long-term side effects most consistently associated with septoplasty, the most common being some residual or recurrent airway obstruction despite the septoplasty surgery. Many surgeries do require some maintenance. Botox requires maintenance. Soft tissue fillers require maintenance. Nose surgery, a good reduction nose job, is once in a lifetime. You get a good result and it lasts. Same with septal surgery. If the septum is reduced, maintained in a stable fashion in the midline of the nose, and you have good airway exchange, there is no maintenance required for septal reduction surgery or septoplasty. If, however, you undergo a traumatic event, baseball to the nose, you slip and fall on the ice, and you break your nose or injure the septum, you may need secondary septal surgery. So care and attention to avoid trauma. Clearly, some trauma would be embodying intranasal chemicals such as cocaine or other inhalational agents are very bad for your septal and mucosal environment. And so properly performed septoplasty with good airway outcome is a lifetime of improvement and requires no specific maintenance. What are some of the common combination treatments with septoplasty? Well, we mentioned some of those. We can divide those into combination intranasal surgeries. And so a good intranasal rhinoplasty surgeon will look for your turbinates, sidewall blockages, will look for functional valves such as the internal external valve, the septum and its position in the midline, and even posterior nasal issues such as polyps, ethmoid air cell issues, obstruction into the maxillary sinuses or blocked tear ducts. Other ancillary treatments that improve nasal function may be done at the same time as your airway surgery. The most common adjuvant or adjunctive surgery is reduction, rhinoplasty or cosmetic rhinoplasty in conjunction with a septoplasty. Then, of course, other cosmetic facial procedures such as upper lid, lower lid, blepharoplasty, brow lift, mid-face, face and neck lift can be done at the same time as a septorhinoplasty, as can any body surgery be done. So adjunctive cosmetic surgery and adjunctive airway surgery are the most common things that we combine with septoplasty procedures. So cost and recovery. Septoplasty, price of septoplasty varies depending on whether it's private pay or managed care covered. Managed care covered septoplasty is covered by Ministry of Health in almost all provinces and most states. If it's private pay, septoplasty surgery itself can run between $5,000 and $10,000. In general, in most countries where there is managed care coverage of airway obstruction, the cosmetic nose surgeon will not charge the patient for the airway breathing or functional part of the surgery. So you're paying for the cosmetic rhinoplasty and you get the septoplasty, functional valve surgery and turbinate surgery at no additional charge because it's covered by the managed care plans. But in general, $5,000 to $10,000 for private pay septoplasty is not uncommon. And it's done for functional reasons, the improvement of airflow. It can be done for cosmetic reasons as a source of graft material and preventative in reducing the nose, ensuring open passageway after a smaller passage is created. So thank you for joining me, Dr. Stephen Mulholland, here in Toronto, Canada on Plastic Surgery Talk with our latest podcast installment, Septoplasty. How do we do it and where does it fit in the scope of cosmetic rhinoplasty? Again, if you find these podcasts entertaining, informative, entertaining, please subscribe, share, and comment. See you next time.